Hi, my name's Elise, and I am the Muppets Academic Coordinator in 2025. Um, and this is going to be the first of several videos that will hopefully help you prepare for the end of the year Apex History Pluses. And the first one that we are tackling today is an approach to Limp. Which I think is something that's probably not covered extensively and you may not see in the wards a lot in pediatrics. So hopefully this will give you some extra tips to know how to tackle a presentation like this. Okay, so in terms of the contents of this talk, first of all, we'll go through an age-based approach and an anatomical approach that hopefully provides you with a framework to attack this presentation. Then we'll speak about history and exam. Then just give some tips for differentiating between septic arthritis and transient synovitis, which can appear quite similar, although obviously septic arthritis is incredibly important to pick up and treat quickly. Then we'll discuss some investigations. We'll just walk through the Royal Children's Hospital protocol for a child with a limp, and then look at some differentials to finish off. So the anatomical approach is one framework that you might prefer to use when thinking about an approach to limp. So this is a systems-based approach or a top-to-toe approach. So first of all, if we're thinking about bones, and some of these differentials we'll speak about more at the end and some are less relevant, but you can think of fractures, non-accidental injuries, very important, osteomyelitis, different types of malignancies of the bone, Sever's disease, which is inflammation of the apophysis of the calcaneus, a SUFI or a slipped upper femoral epiphysis, which we'll discuss further, and Perthes disease, which is avascular necrosis of the femoral head. Then with muscles, you can get myositis or a psoas abscess. With ligaments and tendons as sprains, and Osgood-Schlatter disease, which is inflammation of the tibial apophysis, and also involves the insertion of the patellar tendon. And in terms of joints, we've got septic arthritis, DDH or developmental dysplasia of the hip, transient synovitis, juvenile idiopathic arthritis, and reactive arthritis, which most commonly occurs after GIT infections or genitourinary infections as well. If we're thinking skin and connective tissue, if there's cellulitis of the skin overlying a joint, that could cause limp. Certain hematological conditions like leukemia, which can be known for causing bony pain. An occlusive crisis in sickle cell disease, which is when the sickle cells block some of the blood vessels, and this can lead to ischemia and pain. And haemophilia as well can cause bleeding into joint capsules or hemarthrosis, which can be quite painful. And then some, extra conditions that are outside of the musculoskeletal system, but things like testicular and ovarian torsion are really important to pick up, and appendicitis as well. Then if we moved on to an age-based approach, we can think about which conditions are most common in each age bracket. So in children aged 0 to 4 years, transient synovitis of the hip, excuse the spelling error there, is most common. Then acute myositis, a toddler's fracture, which we'll discuss a bit later, and DDH as well. In 5 to 10-year-old children, transient synovitis and acute myositis are also the most common typically, as well as DDH, but then Perthes disease also comes into this age demographic. In adolescents or children over 10 years of age, stress fractures and sprains are often most common. Then different types of traction apophysitis like Osgood-Schlatter, as we spoke about before, being the tibial tuberosity, and Sever's disease being the calcaneus. And then SUFI is also common in this age group. Then if we think about the conditions that occur in all age groups, we can think of infections like osteomyelitis, septic arthritis, bursitis, discitis, or a collection in the epidural space. Trauma and non-accidental injury are also important. Then different types of malignancies like hematological malignancies, bone malignancies, and soft tissue malignancies as well. Then some different rheumatological and immunological conditions like reactive arthritis, autoimmune arthritis, Hinoch-Schönlein purpura, vasculitis, and Guillain-Barré syndrome as well. Then, as spoken about before, different types of intra-abdominal pathology like appendicitis or ovarian or testicular torsion. Then for hematological, as spoken about, a vaso-occlusive crisis seen in sickle cell disease and haemophilia. And then a functional limp as well, which usually has some psychological type features to it. I won't go too much into this, but this is a really good graphic from the Queensland Children's Hospital, which just shows again the different age groups and the frequencies of the conditions from most common to least common based on age groups. Okay, now in terms of our history, some things that are really important to flesh out would be how long the symptoms have been going on for. Because, for example, there might be a bit more of an insidious onset with something like osteomyelitis. So it might be a couple of weeks of gradually increasing pain, as opposed to a fracture, of course, most likely being an acute onset, although stress fractures might also have a chronic time course as well. Then assessing, is it a traumatic or an atraumatic, which can help break down the causes, the location of the pain, and thinking about, is this referred pain as well? Because a lot of pain that's described as in the hip could be referred from the knee, for example. Then thinking about the number of joints involved, and if there's multiple joints, this might point more so towards a rheumatological condition. Then functional limitations. So can the child wait there? How far are they able to walk currently with their pain, if they can wait there? But really important is just differentiating. Can this child put any weight on that joint at all? Because if they can, we're a bit more reassured. In younger children, looking at birth and developmental history is really important because this can help us to assess the risk of DDH. For example, did they have a complicated birth, quite a traumatic birth? Is there a family history of DDH? Can be important to ask about as well. Then finding out about a recent or coexisting viral infection, which might help us work out if there's a transient synovitis picture going on or reactive arthritis as well, for example. Systemic or constitutional symptoms as well that are quite unexpected, like loss of weight or fatigue or anorexia as well, could point towards some malignant type picture, because particularly loss of weight, obviously in children, is very unexpected. So that should be looked at further. In terms of red flags for history, nocturnal pain is quite a big one because this could point to some sort of bony malignancy. Also a complete inability to weight bear. Because, for example, this would help us differentiate between a transient synovitis and a septic arthritis picture. Looking at those systemic symptoms and recurrent injury as well, because this might point to some sort of pathological process. For example, if a child is constantly sustaining fractures, that might make us a bit more concerned about the integrity of their bones. Or we should also query non-accidental injury with quite recurrent and unexplained fractures, for example, as well. Then in terms of our examination, as always, starting with our general inspection and looking at our patient's interaction with the carer, particularly if we're a bit concerned about non-accidental injury, for example. Then looking at this child, do they appear well or unwell? Because if they're unwell, this I guess, ties in with systemic features, and we might be thinking about septic arthritis, osteomyelitis, or a malignancy, for example. Then we might look for a rash overlying the joint, for example, a cellulitis, which might have led to a septic arthritis. And ecchymoses and petechiae could make us concerned about some sort of hematological condition like hemophilia. We might also be concerned about a malignancy as well. Then vitals are really important, so tachycardia and fever, particularly a high fever, because this might point towards a septic arthritis picture. Then assessing our patient's gait. First of all, can they bear weight? Because if they can, that really reassures us that it is most likely not septic arthritis. Ask the patient to take their shoes off because sometimes, I guess, with kids, their feet grow really quickly, so they might actually just have ill-fitting footwear. In terms of the joint examination, our look, feel, move principles, and make sure you assess a joint above and below. So if they're complaining about the knee, assess the hip and the ankle joint as well, because it could be referred pain, and compare both left and right as well. Then performing a neurovascular assessment of the affected limb, and also, if relevant, an abdominal and or scrotal examination to assess for any tenderness there. Then, as already mentioned, our red flags are any sort of bruising, so ecchymoses, petechiae or purpura, and then a high fever, usually over 38.5 degrees. So I've just got a slide here now differentiating between septic arthritis and transient synovitis, because transient synovitis is always going to be the most common or most likely of the two differentials. And what it is inflammation of the synovial capsule of a joint that typically occurs either concurrently with viral infection or within 2 weeks after a viral infection. And this is quite common, but the child is usually going to be able to walk or weight bear, and usually has a really good response if you give them some paracetamol or Nurofen. Whereas with septic arthritis, they're going to have usually a higher fever, whereas transient synovitis will be a lower grade fever. And these children will have a complete inability to walk or weight bear. So they'll be in excruciating pain, and they often also will not let you anywhere near the joint. There's this criteria called the Koch's clinical criteria, which just helps you predict the probability that it is septic arthritis. So if you get 0, 1, 2, 3, or 4 points, this shows you the likelihood that it is septic arthritis. So the 4 criteria are, is a child non-weight bearing, is their temperature over 38.5 degrees. Then it also has 2 investigative measures as well, so ESR over 40 and white blood cell count over 12,000. Obviously, our investigations are going to differ massively depending on what we think is our likely differentials after we do our history and examination. The ones in text on the left are just some basic ones that are probably most likely to be performed all the time. So an FBE in film, because I guess the white blood cell count could help us to, if we're thinking infection, but I guess all sorts of inflammation and particularly malignancy like a acute lymphoblastic leukemia picture as well. And the film's going to be really helpful there. CRP and ESR in helping us differentiate between transient synovitis and septic arthritis, but noting that if we do have clinical suspicion for septic arthritis, we're not going to be waiting for these to come back. We're going to be referring straight to the orthopedic surgeons. Blood cultures can also be helpful in working out if there's an associated septic picture as well, and taking those prior to commencing antibiotics. Imaging, most useful is going to be a plain X-ray in most cases. This can help us look for things like fractures, also Perthes disease, so that avascular necrosis, and the SUFI as well, which I'll show you a photo of later. And the resource on the right-hand side of the screen is just some more investigations that you might see being performed for a child with a limp. I won't go through all of them, but this is another source from the Queensland Children's Hospital, which is quite helpful. And feel free to take a look at that if you'd like any more information on any of the other investigations. So this here is the protocol that the RCH has if a child presents with a limp. So first of all, it says that a history and exam should be performed, and particularly do an exam pre and post analgesia, because as discussed before, if analgesia is quite effective, this likely rules out a septic arthritis. And getting the child to walk during this assessment is going to be most helpful. If the child's unable to walk and there's features of septic arthritis, then you're going to do an urgent orthopedic consultation. You might do bloods and an ultrasound and commence antibiotics based on the discussion you have with the surgeons. If there's no features of septic arthritis, but they're unable to walk, you would have a look at your imaging, see if there's an abnormality found, and then your management's going to differ based on if there is an abnormality found. If not, and you think there might be an infective cause, you could look at your full blood count, your CRP, SR blood culture, and look at the results, and that's going to help determine your management as well. If the child is able to walk, so right up back again to the top of this flow chart, then we're thinking likely transient synovitis or something like a viral myositis. And we might consider discharge without doing further investigations, but making sure we always arrange a review within about 3 to 5 days. So now just moving on to discussing a few differentials from each category in a little bit more detail. First of all, we have the tibial shaft fracture, which is also more commonly known as a toddler's fracture, which commonly results from a twisting injury in infants between 9 months and 3 years of age. It may not be seen on a plain x-ray initially. So if the child, for example, is referred for an x-ray from the GP or in ED, there might not be any sign of this fracture on initial x-ray. Management of a tibial shaft fracture usually involves referring to orthopedics and a back slab cast for 4 to 6 weeks. Another type of fracture that might occur is due to non-accidental injury. And this usually causes a spiral fracture. And if there's a spiral fracture seen on X-ray in a child, this is a big red flag, because this should make us suspicious about the mechanism of injury. So in history, you might find that what the parent or caregiver says doesn't align with your examination findings, and there might be a delay in seeking medical attention as well. On examination, there might be some bruising seen on the child as well, particularly in pre-mobile children. If there's patterned bruising and it's on non-bony prominences, this is concerning for some NAI potentially. And management will involve mandatory reporting, involving CPS, and of course treating the fractures and other injuries as well. Then a SUFI, or a slipped upper femoral epiphysis, often occurs in adolescents around about that 12 years of age, and it's far more common in overweight children as well. Investigations performed are usually AP and lateral x-rays of both hips, often in what we call a frog leg position as well, which is often the most useful position to be able to see the abnormality. As you can see here on this investigation, so this would be the right hip, and you can see that femoral epiphysis has sort of remained in place in the acetabulum, but the femur appears to be slipped, and yeah, you can have a look in comparison to the left-hand side to help you see that better as well. So management of this will usually be referring the child to orthopedics and surgical fixation as well to prevent it from reoccurring. Then in terms of some types of malignancy that can cause a limp, The first one is an osteoid osteoma, which is most common in the 10 to 20-year-old age group of males. And it's most common in the metaphysis of long bones, as can be seen here in the tibia. You can see this little abnormality here. And then I'm guessing this is a CT, and you can also see that little outgrowth there that the arrow is pointing to. So these children might complain of bony pain that's worse at night and better when they have anti-inflammatories as well. Has a typically quite a good prognosis. And osteosarcoma is the most common pediatric malignant bone tumor that's typically found in 10 to 14-year-olds. When a plain X-ray is ordered, it will have this characteristic sunburst appearance as well, as can be seen in the X-rays down here. And management is often quite aggressive, with surgical resection of the affected bone and systemic chemotherapy as well. Then acute lymphoblastic leukemia, or ALL, being the most common cancer of pediatric populations, most commonly seen between ages 2 and 5, and it's caused by the excessive production of immature blast cells as well, lymphoblasts. Clinical features, so thinking red blood cells, white blood cells, and platelets. So we're going to have our anemia, which is going to cause fatigue and pallor. Leukopenia, the child then might get quite frequent infections, and thrombocytopenia, they're going to have that easy bruising and bleeding. You might also have some systemic symptoms and bony pain, but not always. But I guess in a child presenting with limp bone pain is going to be quite apparent. Investigations are going to be an FBE in film. Particularly in this film, you're going to see high numbers of these blasts. A bone marrow aspirate as well will be diagnostic, and a lumbar puncture will help you assess if there's been spread into the CSF. Management is going to be chemotherapy via different routes, so usually IV, oral, and intrathecal if it is discovered in the CSF. The child might need blood products as well, but I guess this will be all hematology directed. And some final differentials as well. Transient synovitis, as we've spoken a lot already, is the most common cause of hip pain in pediatrics. And often you'll find that the child had a preceding viral ERDI or a GI infection. Usually they have a very low grade or an absent fever, which obviously differentiates it from septic arthritis. If there's no red flags in this child, no investigations need to be performed. And management will involve simple analgesia, resting the affected joint, explaining to the parents and helping reassure them that it's self-resolving, and organising a review within the week. Perthes disease is that avascular necrosis of the proximal femoral epiphysis, which most commonly occurs in 4 to 8-year-old children. And as can be seen in this hip X-ray, there's obviously an increased space between the acetabulum and the femoral head as well. Due to the necrosis. Management is going to usually be observation in children less than 8 years, or an osteotomy, so removal of that affected bony segment in children over 8 years of age. Osteomyelitis often involves long bones in children, and the children will often complain of severe pain and low-grade, or they won't complain of low-grade fever, but they'll have low-grade fever. Risk factors for osteomyelitis will be immunosuppression, systemic illness as well, and different bites or wounds that might lead to cellulitis and then subsequent osteomyelitis. Investigations that should be performed include blood cultures. Initially, plain X-rays might be performed and an MRI, and bone scans are usually going to be most helpful to see that area of osteomyelitis, and a bone biopsy may or may not be performed. Management is quite an extended duration of IV and oral antibiotics. So usually IV flucloxacillin plus or minus cefazolin and switching to oral cefalexin once a child is responding for a total of 3 weeks of therapy. And these are just some of the resources that I used in putting together this talk today. Yeah, I'd really recommend using things like podcasts as well. I used to find them really helpful. And for this one, I used the Master the MRCP, which is a British podcast, but there's also the You're Kidding Right podcast made by pediatric trainees here in Australia, which is also super useful too. So that concludes the first of our approaches in the series for this year. And we'll probably make 4 to 5 this year. If there are any particular ones for your Apex History Plus that you would prefer that we make, please get in contact with us. Or if you have any questions at all as well, via Facebook, Instagram, or feel free to send us an email as well. But thank you guys so much, and best of luck with your study.